Hello, everybody. Welcome and kumusta. Thank you for joining me. This is How, your occupational therapist, and welcome to OT Conversations. In this episode of OT Conversations, I'd like us to have a discussion about muscle testing and muscle grading, and the very, very popular one that we are using all the time would have been the Oxford scale. And scale muscle grading is very simple. It is from 0 to 5, where 5 is being, the muscle having a normal strength. 4, if there is some slight weakness. 3 is given if the muscle joint can move against the gravity, and you give a score of 2 when it can move against gravity but not in full range, so just barely moving. 1 is if it's trace, meaning there's only flickers and you cannot see muscle contraction at all. And then 0 is when somebody has no movement at all. So that is the Oxford scale. That's commonly used, easy enough. Do you know, though, that there is a much more detailed scale that is available out there, and it is broken down into sub-steps? I don't know if it is Kapanji, but it is very useful, particularly when you are using it in neurology and when you are doing some more thorough motor retraining for most of your patients. So the grading would go like this. 0 is the same, no contraction. 1 is the same, where there is a flicker of muscle movement. Now, you would get a score of 2 minus for those muscles that can move against or not against gravity in a gravity eliminated plane, but they are actually weak and it's not in full range. You get a score of 2 if it is a full range in a gravity eliminated plane. You can get a score of 2 plus, full range in a gravity eliminated plane plus some resistance, but it is a gravity eliminated plane. 3 minus would be given if a person can move that joint in a gravity against the gravity, but with some slight resistance, or against gravity, but not in full range, right? So that's 3 minus. You put a score of 3 for that movement in full range against gravity, 3 plus with mild resistance, 4 moderate resistance, and 5 if the muscle is back to full strength. All right? Okay. So it is much more precise, it's nuanced, and it is useful for tracking progress in very small increments, and it's very helpful and very useful when you are doing motor retraining. Okay, but here is the big question, right? The big question would be this: so what? Now, I am not saying that you shouldn't know these grading systems. You really do need to know this by heart. This is the tools of your trade. It's an assessment. That's how you measure strength, right? The question is, why are we isolating the individual muscle movements when there can be, or you may be facing some conditions that do not present focal weakness, right? So there are conditions that would present like focal weakness and specific muscle groups. For example, peripheral nerve injuries, for example. So you can have, say, musculocutaneous nerve, which will affect the biceps. Which again, how does one injure the musculocutaneous nerve, isn't it? But you can have radial nerve, axillary nerve, median nerve. And then, yes, you can isolate the muscles and you can identify it. You can measure the strength for these muscles. That's fine. Okay. But for central nervous system problems like stroke, right? The weakness can be global. It is not isolated. So if you grade just one joint, say you're grading the wrist extensors, you're not really seeing the entire picture. right? So when you're thinking about the muscles and muscle strength, you have to think about the entire circuit of the movement. And what do I mean by that? When we do muscle testing and strengthening, the entire circuit has to be intact. Meaning, number one, the muscle structure should be there. It should not be injured. The nerve supply, that's second. Nerve supply should be there. The pathways and the tracts should not be impaired as well. And then the control mechanism in the brain should be there as well. If at any point there is a break anywhere in this circuit, especially in the central nervous system, then we are no longer dealing with a very simple biomechanical problem. It has now become a neurological concern, and in this case, it will not be fair to measure the strength in the usual way because the muscle is at a disadvantage. Why? Because it's not receiving the proper control or input, right? It's almost like assessing somebody's speaking and you're saying that their articulation is bad when in fact they don't have a tongue, for example. So you cannot be fair in assessing somebody's communication when part of the mouth is there's an injury in there, and that's just an analogy, okay? Now, why do we still have to do these measurements then? We measure it because it gives us a shared clinical language amongst ourselves as clinicians. So it gives us a shared clinical language. Say if I write the upper limb is grossly graded as 3/5. If I document that, you'll have an image of what that patient actually looks like. Then the person can actually move the upper limb against gravity, but it's not strong enough against resistance. And if you document it in that way, it helps us to communicate quickly, and we'll be able to compare sessions from previous ones that have been documented and then track the progress, right? So look, say you're reviewing the notes and you've seen the doctor make a grading score of 2/5, right? Yeah, that's what they have assessed at that point and at that period of time. And if you see them and the muscle grade has improved to 3 or 4, it's not that the doctors are wrong, right? It's just that at that point of time, that's what it was, and now you start with something again, right? Yeah. And what's nice about the grading system is that you can break down, more details about the movements of the arm. For example, the shoulder abductors are like -3/5, and you know what that would do. Or if the elbow flexors are -3/5, you know what that would do, right? Wrist extensors of 2+/5, you know what that would do, right? So these details will help you describe not the strength really, but it helps you describe also the motor behavior, right? So I have a few tips for you guys. Tip number 1, as a clinician, whether you're a learning student or a clinician who has forgotten about this, tip number 1, know your prime movers. This is important. And prime movers for every joint and every plane and which muscles are working. For example, shoulder abductors. If we're talking about the shoulder abductors, then we're talking about the deltoids, the supraspinatus muscle. If you're thinking about the shoulder flexors, for example, you're talking about anterior deltoid, some the pectoralis muscle activity in there. Maybe is it really? But it's more anterior deltoid. Now, the external rotators, you can have the sits muscle, the infraspinatus, the teres minor, yeah. I believe latissimus dorsi, or can that be? Well, just review, okay? And then say punching forward or moving a forward movement and pushing forward of the arm. That would be the serratus anterior. So tip number 1, know your prime movers, right? And it's easy to do that. There's only a certain group of muscles that are active. Good. Okay, tip number one. Here's tip number two. Know what would be their nerve supply. Like, for example, if you're doing thumb movements, so that would be the median nerve. If you have the power grip, that would be more of the ulnar nerve. If you have this type of movement, flexion of the thumb, again, median nerve. And if you're thinking about wrist extensors, then that would have been radial nerve, right? Once you know the muscles and its nerve, then you can locate the site of the problem and the lesion, right? If there is a problem. For example, if the grasp is weak, but say if this is weak and other functions are normal, then you are likely dealing with peripheral nerve injury. And then you can locate where would the impingement be, right? For a stroke, then it's central, so you know that it's the brain. For a spinal cord injury, you can locate the level where the problems are. Okay? Now, let's talk about some of the interventions. We've gone through knowing, right? Knowing, recording, right? Now, treatment. How are you going to deal with this? Your treatment can either be restorative intervention or it can be compensatory intervention. When you plan your intervention, you always ask yourself, is the circuit complete, right? And then the next thing is, do I have enough time to restore this function? Yeah. If yes, you have enough time and the circuit is complete, then you would go for restorative interventions like biomechanical interventions, for example. You can do resistance training, progressive loading, repetitions, PNF techniques. You can do it over and over and over again, yeah? And if you have enough time, do it, as much as you can. Restorative is your priority if you are a clinician, right? Now, if you do not have that time and the luxury and the system is just not complete yet, say patient nerves needs to regenerate for months, right? Or there is a brain problem that limits control, then you have to start thinking about compensatory strategies, especially if the physical prognosis is quite poor. You go by the preventative approach then, right? And this is where occupational therapy is very, very helpful, right? When the muscles can't do it, we can teach people how to perform those daily tasks through adaptation, right? Functional tasks and occupational tasks, ADLs, has always been the concern of occupational therapy, right? Okay? Although there are a lot of therapists out there, other professionals who's now doing the ADLs, but it's wrong, okay? It's technically illegal when you do something that is outside the scope of your profession, right? So ADLs, ADL retraining has always been ours, all right? So are we, as occupational therapists then, are we still allowed to do strengthening activities, right? Yes, of course, we are fully allowed, yeah? Because these are all performance components that we are talking about, and performance component is another domain of the profession of occupational therapy. So yes, you can do ADLs or strengthening activities, particularly when you document it as a preparation for ADL retraining. So the key is to understand the context, and the question is, are we restoring or are we adapting, right? Okay. Either way, the justification should be because of occupation. Right. So, whew, that was a quick talk. There you go. It is a simple reflective piece about muscle testing, muscle grading, and what it really means. So knowing is good. The scales are important, but what's really important is, what are you measuring? Why are you measuring? Right? Okay, guys? So know your muscles, know your nerves, understand the cause. And from there, you can start planning your intervention, whether it's going to be a restorative intervention or compensatory intervention or adaptive intervention, right? Well, there you go. If you like this session and you learned a little something, do us a favor, like, share, subscribe, do what you can to please the algorithm. Talk to your friends about it. Learn together, grow together over a cup of tea. Just remember, anything you do matters and has an outcome. This is how your occupational therapist. This is OT Conversations. Until next time, bye.